Thank you for the opportunity to present our data on outcomes following laparoscopic transhiatal esophagectomy for esophageal cancer. We have no disclosures to make. Traditional open resection for esophageal cancer has been associated with high morbidity and mortality, and minimally invasive techniques were applied in an attempt to minimize operative trauma while maintaining oncological principles. MIE was first reported by Kasheri and colleagues in 1992, and since there have been numerous approaches described. Most involve some combination of thoracoscopic and laparoscopic techniques, and endoscopic techniques have been employed for high-grade dysplasia. Population-based studies have shown a dramatic rise in the utilization of MIE, but despite some improvement, complication rates have remained persistently high. Laparoscopic transhiatal esophagectomy was first described by DePaul and colleagues in the mid-1990s. And it avoids any direct thoracic access, which offers the potential to minimize pulmonary complications, but the technique has not been widely adopted as other minimally invasive approaches. The objective of our study is to compare laparoscopic transhiatal esophagectomy to a historical cohort of patients undergoing open esophagectomy. In this retrospective cohort study, we analyzed all patients undergoing laparoscopic transhiatal esophagectomy from July 2008 to July 2012. And compared them to a historical cohort of open transhiatal and en bloc esophagectomies from July 2002 to July 2008. Perioperative outcomes included length of stay, blood transfusion requirements, and lymph node yield, and primary outcomes included recurrence and overall survival. The operative technique includes a circumferential transhiatal dissection of the esophagus via ports placed in a standard Nissen configuration and celiac lymphadenectomy. Then dissection of the cervical esophagus, followed by tubulization of the stomach with GIA staplers and creation of a hand-sewn cervical anastomosis. Jejunostomy tubes were routinely placed for postoperative feeding. On demographic analysis, the en bloc cohort was seen to be significantly younger, with fewer comorbidities overall, and lower prevalence of each subgroup of comorbidities, except for the prevalence of diabetes. Perioperative outcomes showed significantly shorter median length of stay and packed red blood cell transfusion requirements for the laparoscopic transhiatal group, with operative times being equivalent between the laparoscopic and open transhiatal group, but both significantly lower than the en bloc cohort. Tumor staging of the cohorts showed a significantly lower number of stage 1 tumors in the en bloc group. The laparoscopic transhiatal group also had a higher percentage of patients who received neoadjuvant therapy and a significantly smaller median tumor size. The median lymph node yield were 24, 36, and 48 respectively among the laparoscopic open and en bloc groups, with the laparoscopic transhiatal group being significantly lower. The percentage of patients with positive lymph nodes was equivalent among the groups, and recurrence was also equivalent with no difference in the ratios of local, regional, and systemic recurrence between the groups. Considering morbidity and mortality, the major complication rate was significantly lower among the laparoscopic transhiatal group with equivalent leak rates among all groups, and there was a slight trend towards lower pulmonary complications in the laparoscopic transhiatal group. The Kaplan-Meier survival curve estimates 24-month survival at 70%, 65%, and 65% for the laparoscopic open transhiatal and en bloc esophagectomies respectively, which was not significantly different. The median follow-up time for the laparoscopic transhiatal group was 26 months. In conclusion, we've shown that laparoscopic transhiatal esophagectomy has less major complications in blood loss, shorter length of hospital stay, and equivalent recurrence and survival. We therefore feel that laparoscopic transhiatal esophagectomy is an appropriate and safe approach to esophageal cancer resection.
Thank you, Dr. Cash. Very well presented. So this paper is now open for discussion. Questioners, just come on up to the microphone. Sir, state your name, please.
Ahmed Hafiz from Egypt. I work in a cancer center, and we do a lot of minimally invasive esophagectomies.
Yes, sir.
But our trend is to do the thoracoscopic, laparoscopic approach with the patient in the prone position in the thoracoscopic part. Because now the main emphasis is on the extended field lymphadenectomy in the chest, and you need to go as high as the recurrent lymph nodes to do a good radical procedure. So why do you insist, while you have the option of doing a minimally invasive procedure in the chest using thoracoscopy on the Trans-Hiatal route and compromising the radicality of the procedure?
Well, we've shown that even though our lymph node yield was significantly lower, that survival wasn't affected overall. So we feel that we're not necessarily compromising the oncologic feasibility of the procedure, and with the benefits to the patient of the shorter hospital stay and hospital morbidity and those things, that it can be beneficial.
Yeah.
Tony Petrick from Geisinger Medical Center. Hey, you have 3 study groups and you show us 1 p-value. Are you combining the open and on blocks as a group that you're comparing that the laparoscopic against?
The ones that we showed were comparing the p-values between all 3, but they were independently analyzed also.
So you're comparing laparoscopic against each of the other 2?
Yes, sir.
Other questions? Since you were comparing 2 different time periods, were there any other changes that occurred in the environment or in the way you cared for the patients between those 2 time periods that could explain the differences?
They were both carried out at the same medical center by a similar group of surgeons. Being at a different time period, I would say that the increasing use of neoadjuvant therapy was probably the main difference between the historical cohort and the more current one.
And is it possible that plays into your findings, or?
Certainly could.
Other questions on this paper? If not, good job, Dr. Cash.
Thank you.